Welcome, everyone. Thank you for joining us for this webcast, The Impact of Obesity on Employers, sponsored by Diabetes Leadership Council. This webcast has been pre-approved for HRCI and SHRM credit. Please be sure to attend the complete webcast in order to receive your credits. If you have any questions during the webcast, click on the Q&A tab in your webinar controls and type them there. It is now my pleasure to turn it over to George Huntley of the Diabetes Leadership Council to introduce our speakers.
Thank you, Hester, and good afternoon, everybody, or good morning, depending upon where you happen to be. I am George Huntley. I am the CEO of the Diabetes Leadership Council. I am a patient living with type 1 diabetes for 42 years, and a little bit further in my background, I spent most of my career as a finance professional in manufacturing and professional services. In that role, I've been the plan administrator of an employer-based health plan for over 25 years in a variety of those industries, including in a union environment. So I welcome this audience, and I really appreciate the opportunity to be here and be part of this program. Disclosures, we have two presenters that I will introduce and when we get to that part of the show, Dr. Eden Miller and Dr. Mary Himmelstein. Both of our presenters, the program is sponsored by Eli Lilly and Company, and both of our speakers receive an honorarium and also share their expertise with Lilly on occasion. The Diabetes Leadership Council. We are a 501c3 nonprofit. We are a policy shop. Everybody on our board is a past leader of a national diabetes nonprofit. We are patients, we are parents, we are healthcare providers, and we educate lawmakers, policymakers, advocates, and through sessions like today, employers, on issues that are important to the health of people living with diabetes, and again, in this instance, obesity. I'm going to, too far. Today's program is on obesity, as we know. It is the number one driver of type 2 diabetes, which is why the Diabetes Leadership Council is here to talk about obesity. It's the one chance to actually bend this curve. Obesity is a societal problem. We're going to talk about this today. We're going to talk about the employer's role in this and some of the decisions that the employers are making and where we stand on things. We got a packed agenda, but please, as questions come up, please put them into the Q&A, and we will get to as many as we can through the program, and we will try to answer the ones that if we don't get to them, we'll follow up afterwards. We're going to cover where we are in obesity. We're going to cover the disease of obesity. We're going to talk about stigma and bias and how that's impacting your workplace and some of your HR decisions. And again, don't hesitate to ask us a question. So let's start with obesity is a fight we're losing, frankly. And I don't know that that's a shock to everybody, but we're to the point where about half of the adults in this country are living with obesity. We're getting very close to that point in that curve. And the trajectory is very disturbing as we go forward. I don't think that's a surprise to anybody. Also, obesity is a public health crisis, and we don't talk about this in the terms of what it is. It's second only to smoking in preventable deaths in this country. 1 in 5 deaths in African Americans and Caucasians aged 40 to 85 is attributed to obesity. 20% of the deaths. 200 medical conditions can be linked to obesity. We're going to talk a little bit more about that in a minute. As I mentioned, 85% of people with type 2 diabetes are either overweight or have obesity, and it raises absenteeism, injuries, etc. It costs a lot of money, and we're going to talk about that. It was only declared a disease by the American Medical Association back in 2013. So as a disease in this country, it's only 12 years old. I did that math in my head. The World Health Organization's declared obesity disease back in the 1940s, but in the American Medical Association, Took until 2013 to do so. And that delay is, part of why, we're behind the eight ball and behind the curve on treating it. And if I can get the slide, there we go. So where is obesity happening in the United States? Short answer is everywhere. But unless you live in Colorado, where people are climbing mountains and apparently are a bit fitter, and California, interestingly enough, has one of the lower rates. Washington, D.C., they must be walking up Capitol Hill and down all the time. I'm not going to make any political comment there other than most of the country has a very, very, very high concentration of obesity, and specifically that lower southern belt between Texas, Oklahoma, South Carolina, and then straight up north to North Dakota, that you see a very high incidence of obesity. If I showed you this same map with diabetes, it would look the same. The diabetes map and the obesity map are nearly identical. So average age of obesity. Obesity is starting at a younger and younger age. And that's a problem. And again, we'll touch on this in a second when Dr. Miller speaks with us. But the earlier you become obese, the more it shortens your life. The more you are more likely to have some of the complications that go with obesity. So it is something that we've got to capture and talk about right now. It's also the working age population. Why are employers talking about it? It's the working age population that are living with obesity. And you look at what happens as people age 65 to 74, 75 to 84. Those people are not getting fitter. They're dying off primarily. So by the time you get to the lower, it's shortening people's lifespan, which is important for us to understand and hopefully get involved from a health perspective. Also, interestingly and importantly, is the educational gap that happens in obesity. Those with a bachelor's degree are far less likely to live with obesity than those with a high school education or only some college, which means this is a disease where education is important. And when we get into, the importance of education within how do you live with the disease, some of the lifestyle management, and just even being aware of the treatments of obesity, education is really important. And employers play a really important role in that. We're going to talk about, there's a question in here, were the biases present when developing BMI measurements factored into the statistics and charts? The short answer is no. We're using the best statistics that we have, and I'll ask Dr. Miller to weigh in on that when we get into that section. But I wanted to acknowledge the question in there. Thank you for that. And I also want to talk very briefly on health equity. Equal access doesn't mean everybody can actually have access. So that equality side of it, everybody has equal access. Everybody has an equal opportunity. So it's an equal opportunity, but it is not equal access. I said that backwards, and forgive me. Equity allows equal opportunity so that we actually have to do things to make sure those that are underserved, under-resourced, or whatever actually have access to the treatments needed. We're looking for health equity in this plan. And ultimately, let's remove the wall itself, and that may be by curing the disease. We'll see how that plays. But we have to really pay attention to it because obesity hits minority communities harder. If you look at the Black and Hispanic communities versus the white communities, in the obesity, a BMI over 30, each of these areas, the Black and brown communities are hit harder than the white communities at every step of the way here. And so if knowing your own demographics of your employee population is important to say, what do you need to do or should we be thinking about in getting access to care? And what does obesity cost us? I went a little too far there, but obesity costs 2.7 times more in healthcare spending than for someone who does not have obesity. This is from the Kaiser Family Foundation, and this is a review of their commercial plans, employer-based plans, from 2011 to 2021. I don't have an update on that, but hopefully we all know that it didn't get better. And it's interesting to start seeing what that healthcare spend delta is, because it's growing. That delta is getting bigger and bigger as the comorbidities are getting bigger and bigger, and we're getting more and more aware, because it's a relatively new disease, and people are not being diagnosed with it. They were not being diagnosed with it. The factors in this particular study were those in the Kaiser Family Foundation that actually had obesity diagnosed in the patient record. And it's being very much underdiagnosed. So my guess is strongly that this is underreported versus overreported. And then looking at the cost of obesity for workers. No, I see another question. Are we talking about people with obesity and diabetes? No, that is just obesity. Now, chances are many of them also have diabetes, but that study was about obesity alone and not a combination of obesity and diabetes. That was a study just on obesity. But of course, many, if not many of them did in fact have diabetes, but that's not what the study was there to do. It's giving you the total healthcare costs of a person with obesity. And you take that and you add presenteeism and absenteeism and disability to it, you're looking at an overall cost of $12,700 over a person who does not have not have obesity in this. It's a big number that isn't being recognized by a lot of employers. It's just underreported. We haven't really been talking about it very, very long. So, we know what some of the costs are of treating it. We're starting to learn those, but we haven't really paid a lot of attention as to what's it actually costing us today. And there is such a number of factors going on here. And there's another question that said, do we have an intersectional information that shows the relation between race, education, and other factors? I don't in this particular study. We do know, I do believe some of that information exists between race and education, and the social determinants of health in obesity is a huge factor. So I'm going to, absolutely, this is what I've got right now, but there's a lot of studies going on that dive deeper into the ethnicity issues. And, we saw education, we saw racial, we saw, there's some which I don't have on here, based upon how much income. And, no surprise, lower income, lower education, et cetera, worse disease outcomes. And that's true for diabetes, it's true for obesity, it's true in a great number of areas. I want to get into the conversation on obesity, so I'm going to ask Dr. Miller to please join us. Dr. Eden Miller is an osteopathic board-certified family practitioner. She is certified in obesity management and is the CEO of Diabetes and Obesity Care in Bend, Oregon, in lovely Bend, Oregon, although I don't think that's where you are today.
No.
But I welcome you and thank you for joining us.
Hey, George, great presentation and great questions. I feel like we have an audience that is really kind of distilling down. And so with that, I'm going to answer some of those questions that were kind of in the chat. And so if we go to the next slide, we're going to see a bit about BMI. And BMI is a metric. Metrics are fallible. You could talk about high blood pressure, and measuring a blood pressure is not the same. Nobody does it the same technique. And so when we look at metrics, it isn't an absolute. There's not a lot of absolutes in medicine. And one of the things that has always come to the top of mind is the BMI the best way to determine rates of obesity. It's probably the quickest. If we looked at height, if we looked at waist circumference and hip circumference, it might be a better, what we term excess adiposity. And that's what gets thrown around a lot is, do you have excess adiposity? Because no, I'm sorry, we are not all like Venus and Serena Williams. We don't have this very high muscle mass. Now, let's talk a little bit about the ethnicity differences. It is true that those of the African American culture and heritage and ethnicity, they can have a higher BMI and not be considered overweight or obese. We don't tend to tease them out as much, but us as obesity related specialists, we have maybe a different target. So when you look at maybe that data, you might say, well, those with a higher BMI of African American, but remember that slight difference doesn't make up for the big difference we see. Now, conversely, which is something we don't talk about as well, if you're of Asian descent, you can have a lower BMI and be considered overweight or obese or at risk. So you're right. We're talking about excess adiposity. And we could all talk about underwater weighing, electrical impedance, bone densitometry or body composition densitometry, or even MRI, but we're not going to do that because it's about talking about the masses and it's talking about identifying those individuals and starting the conversation. And it does affect people of food deserts where they live in the inner city. They can't go out. It affects people who have low income or high income. It helps people. And do you know an interesting statistics? If you're African American and you tend to be low income, the males are thin, but the females are heavy. And if you have a high affluence and you're African American, the males are heavy and the females are thin. Go figure. So don't get lost in the exceptions. Let's talk about what's in front of us. We are carrying excess weight as a country, as a nation, and as the world. And we have BMI, and this is how we classify it. Now, I will tell you a little bit, when we see these classification, we call it obesity class 1. We don't usually like to call them obese because we don't want to be labeling people because we're going from that blame to biology. And let's go into a little bit more about that biology.
So before we do that, I do want to just touch on this, the body defending that set point. I think that's a point that it's really important to make because, people, you do the best you can, you get to a certain weight and then you lose weight and then it comes right back. And
I
that's
hear
your
it all the
body.
time.
That's normal.
I hear it all the time. And here's why. We are built for famine. We are not built to be fed. We want to be built for famine, especially us women. I tell the women sometimes, not that I'm not talking to the men either, but I tell some of the women, you were built to nurture, to have children. I'm not saying that's our only sole purpose, but as the same way that is that if we lose weight, the body's going to try to defend its highest weight. And I know some of our listeners are like going, yes, I've experienced that. In fact, the body will sometimes gain more weight because it says, oh my gosh, you tried to kill me. You tried to kill me last month by doing this weight reduction. And that's a natural adaptation for when we go through times of famine or illness or lack or seasonal. Now, it might say, well, none of us are doing that. It could be why we are having trouble with that. It's our environment, it's our biology, and it's how we're made to defend that.
Yeah, it's a source of frustration for millions of Americans. But it's good to know that you're not alone. But there's a biological reason for it, and again, we got to go from blame to biology and working through this. So I appreciate that. And the good news is, from a health perspective, you don't have to get back to your high school weight to get the benefits of better health and by losing some weight. So losing 10%, 5% of your body weight. Give us a little bit of good news.
Yeah. The first thing we want to make sure that you get away from this is that this is a chronic disease. This is not blame. This is really so many factors related to it. The second thing I want you to get from this is that even in my practice, and I educate my colleagues, they think individuals have to lose such massive amounts of weight to improve their health. I hear them even say to me during conversation, oh, my patient needs to lose 100 pounds. And I'm like, really? Your patient needs to start with 5%. And imagine if you're sitting here as an encourager, as a health benefits administrator, as somebody who's a friend or a clinician, or just all of us, even our own health, we say a 5% body weight reduction or more has improvement in these metrics. Do you know the metric we see that improves the fastest? High blood pressure. High blood pressure improves the quickest. But we also see diabetes. Now, I want to talk a little bit about the fact that diabetes isn't the only comorbidity. There's cancers, there's joint replacements, there's all of that. Now, if we go to 10% body weight reduction, which is the first goal, that's the first goal on many different things. The Heart Association, Kidney Foundation, diabetes, 10% body weight reduction can talk about diabetes remission and sleep apnea. Sleep apnea, we get better quality sleep, we get less work absenteeism, we get less of those comorbidities. Now, when we go to 15%, that is where we start to see cardiovascular mortality and cancers. Do you understand the obesity is the greatest risk for cancer? I know we talk about, oh, it's tobacco, oh, it's this. No, it's obesity related things. So many of us can either think of ourselves or even individuals in our life that we help encourage that a 5 to 10% body weight reduction, that's achievable. It's absolutely achievable.
Yeah, and that's really important. And I mean, you had me at improved incontinence, but when you get to sleep apnea, and now my wife's happy because I'm not snoring, and it's all good. It's all
Yeah.
good, and that is really important to give people a little bit of hope in that. And now let's get back to that bad news of the 200 comorbidities with obesity, and hit us again on the cancer, all the other things. That this is why obesity is expensive. People were looking at that $12,700 and thinking that can't be real. It is. A diabetes, the cost isn't diabetes, the cost is kidney and obesity.
Yes. So there are so many different medical conditions that are related to this. You know, we have issues regarding heart disease and cardiovascular disease, which is kind of a lumped together. I don't want our listeners to think that this is just diabetes related. I mean, I like to term obesity as dysfunctional metabolism. When you have dysfunctional metabolism, you get it expressed by all of these, what we call comorbidities or consequences of dysfunctional metabolism. And I can tell you, I don't think there's a disease that isn't impacted by obesity, right? Show me one that isn't. You know, maybe nearsightedness, maybe, I don't know. I think that just gets as you age, right? And so you even mentioned incontinence, and we don't want to have it ad nauseum thing, but let me put it this way. If we impact the core problem, all of the periphery gets better. And guess what we're doing right now? We're treating the periphery, but we can treat the core, and we can do two things. We can prevent disease and we can treat disease. And this is where, who's going to take the first step? I liken it to be like a lifeguard rather than pulling people out once they've drowned, right? And I know that sounds dramatic and like almost a little scary, but it's true. And we have to have a preventative mindset, because you want to talk cost. These diseases cost billions more than treating the core problem.
Yeah. And that is where the dialogue needs to get to. And I thank you for pointing that out. And unfortunately, it is vastly undertreated. And this stat, and I just talked to us a little bit about this. It's undertreated. It didn't used to even get reimbursed. Give us a little insight as to this.
Well, I'm going to tell you a story that really got me to change from family practice to go to get my fellowship in obesity medicine, then my fellowship in diabetology, because those are my wheelhouse. I had a patient come in for a physical, and we got near the end of the physical. This was a good decade or so ago. And she said, "Dr. Miller, this is my health and wellness visit, and you never asked me about my weight, what I thought about it, and what I should do about it." And can I tell you, that was a sobering moment. And not from the standpoint that I felt criticized, but rather, I think as a clinician, we don't talk about that because we're hyper empathetic and we don't want to hurt their feelings. But the reality is, I'm their health Sherpa. And my job is to usher them, not to necessarily hike for them, but to usher for them. And so what we see is we're not even talking about it. And I know there's a slide coming up talking about if you just talk about it, you can have a major impact. And so that is my job of educating colleagues to talk about it. And here's how it makes a difference. You got to have a conversation. And if we look at the BMI, you might say a BMI of greater than 26, that's like, whoa, 60% of the population in the United States are either overweight or obese. That's a lot of conversations. And many of our patients have never been told. And so if you're never told, you don't tend to intervene. But if you're told, or if you're, that's where the art comes in. How do we start the conversation? And guess what? I see a lot of kids. Like the other Dr. Miller and I see kids. And the first thing we don't say is, what do you think about your weight? And how do you think? We say, do you think you're the healthiest you can be? What are the things that you need to be healthy? And we talk to adults the same way. Do you feel like you are the healthiest you can be? What are some of the things? And then I said, did you know that a 10% body weight reduction, like you said, so many of my clients go, oh, I got to look like I did in high school. Guess what? You're going to look terrible if you look like you did in high school. We aren't teenagers anymore. And again, our job is to not look good in a swimsuit. Our job is to move our body in time and space, to have an appropriate metabolism in order to live the healthiest life.
That's well said and really important. And now let's talk about how we could and should be treating obesity today, because there's 3 steps along this path. Let's just start with the lifestyle management, I start with education. We've shown those without education, are much more likely to have obesity and be dealing with obesity. We know, and I think Elliot Joslin, who is a famous doctor in the diabetes arena, said those with diabetes who know the most live the longest. It's a health situation.
Yeah.
Talk about the importance of this.
And unfortunately, our health is not taught at home, nor is it taught in schools. And so these are those opportunities for creating that awareness. The nutritional counseling also goes to just knowing how to cook. Some people don't know how to cook. They don't know where their food comes from. They don't understand that the body likes certain things. They're not even aware of limiting processed foods, or what we call intact or from the ground. We are not advocating everybody have one particular diet, everybody vegetarian, everybody this. No, it's about something that works with themselves, their culture, their family, their economics, and there always is a way to find that. Also understanding behavioral and movement. I don't say exercise, they say movement. And the fact that I want you to do something that you're going to stay on for the rest of your life. This is not, I get this all the time. Oh, Dr. Miller, you're only doing anti-obesity, you're not doing lifestyle. I'm like, no, I'm not. Anti-obesity medications are a life jacket for people who are drowning. Now, some of the people may not agree with that. They may think, oh, they just need to learn how to swim. Oh, they just need to learn how to diet and exercise. It's like, how has that been working? It's not. Every person that comes in and I talk to them about anti-obesity medication, it's trying to go against that hormone conspiracy against you, like Dr. Campos says, right? And so what I say is, I'm giving you a life jacket because you're drowning, and I'm going to teach you how to swim. I'm going to teach you how to do the lifestyle. We're going to figure it out. And then in some cases, there are some that have such penetration, whether it's genes, whether it's environment or lifestyle, or you name it, we have to go to bariatric surgery. But you know what? We're not going to be doing that with the vast majority of people. How come? Because some of these treatments out here, George, are as good or better than bariatric surgery, and their risks and their complications. And it's fascinating to see it. And just look at the bottom. My husband is doing tons of work in pre-diabetes prevention, and the data with tirzepatide, just focus on that for a second. You use tirzepatide for people with early type 2 diabetes, 94% prevention. Sorry, it's going to be controversial. That's better than vaccines. I mean, that's just an amazing idea. But these are your roads for interventions.
So that was a lot to digest, pun intended for the audience. But I do want to say a couple things for the HR teams listening to this. Back in lifestyle management, we talked about education. You guys are thinking about wellness programs. I think hopefully you can take away nutritional programs, behavior, access to some of those things can be part of your wellness programs. We're gonna end on wellness programs, but I want to take this moment to reinforce it, and I'll remind you again at the end. But that's really important. The other thing I want you to go back and look at your health plans. As a plan administrator of a self-insured health plan for 25 years, and now I'm in this space, nutritional counseling is not covered by most of your plans. Behavioral therapy is not covered by most of your plans. Smoking cessation classes all day long for as many times as your employee, your plan participant wants to try to quit smoking. You will go all day long and give them as many smoking cessation courses, yet you're limiting them in nutritional counseling, behavioral therapy. That is the cheapest end of the treatment phase. Then you go to AOMs, and now you talk about AOMs. Now we're at the point today, our study came out last month, it's about 10 days old. About 36% of employers are now covering the GLP-1s. That's way up from where it's been.
Way up.
And for all of the reasons we advocate for this, and it's financial decisions are difficult, okay? But the ROI on this is just beginning to be understood. We do know now that it cuts and bends that cost curve, that trend on the second year. On a GLP-1 is half of what it was for somebody without it. So that data is.
Kevin, are you on the internet?
Oh, can you hear me now? Okay.
Yeah, sorry,
That's okay. So we're working on what all that looks like. Most of the health plans will pay to do the surgery, the most invasive and expensive thing on there. Look at your plans as to what you're covering and what you could possibly reduce. The other thing I want to say here is there's a lot of GLP-1s coming on this market. GLP-1s have been around for well over a decade. I want to say 2005. The first one came out. People think, oh, this is a new drug. It's not a new drug. No. It's a new iteration of that drug. And
it's a new label.
Yeah.
New label, new indication. And some of you are looking at this going, well, wait a minute, oral semaglutide, these are all weight loss indications. Don't get confused. Many drugs are diabetes related drugs that have the same name as weight loss drugs. So don't be confused. These are not like we're just throwing things in here. These are trials that are coming. And as you alluded to just very quickly, some of these newer agents, some that are just been approved, like tirzepatide and injectable semaglutide at a higher dose, these percentage of weight losses are like 15, 18, 20% body weight. That's average, not like the super responders. That's average. That means that the average participant can do that. And then one last final thing with this, George. People say to me all the time, well, they're going to have to stay on it. Well, if you and I took off our glasses, we would not have very good time seeing, right? There's not a lot of legacy effect. Yes, we may reduce a dose like a micro dose or a maintenance dose, but these meds are fixing the problem because it is a multifactorial problem. And these may need to be maintained until something else comes around. It's not like you go on a diet so you don't have to use your glasses anymore.
Yeah, it's like it's a hormone replacement. You stop taking the hormone, the problem comes back. You're on a statin for cholesterol. You stop taking the statin, your cholesterol goes high again. It's not a shock. The drug works. The other piece I want to point out here, look how many drugs are under development.
Yeah.
Not all of these will make it to market. That's the risk of drug development. Not all of these are going to hit the market, but many will, several will. This is the one drug class that I can, in my memory, that the price of the drug has dropped precipitously in the first 2 or 3 years of its existence. And there's been a lot of factors that we can go all day long on that. But the good news is the price of that drug is dropping. Still high, but you can now get these from the manufacturers at $500 a month. It's not $1,400. Again, $500 is still
Yes.
not cheap. As we get into this and you get more and more competition, you're going to see the price continuing to decline. I'm not going to promise or project where it's going, but it is a class that competition is going to and has already proven effective in that. So it's important for the employers to think about as they're making the economic decisions about how to cover and where to go.
And they are, to be fair, George, they are biologics. A lot of times we talk about these being drugs. They're not really, they're hormones, and they're biologics that are expensive to make. These are recombinant DNA, E. coli driven PCR hormones that we are getting from these biological engines to replace. So even though, yeah, they're drugs and they have a prescription, they're hormones and they are not cheap to make. Things will always innovate and get better, but they're not just a chemical that we're just repeating.
Yeah, and that's a really important point. Dr. Miller, thank you so much
Thank
for
you so much.
sharing with us today. Really, really appreciate it. And I'm now going to invite Dr. Mary Himmelstein to join now, and we're going to shift the conversation to bias and discrimination. Dr. Mary Himmelstein, very quickly, is an associate professor at Kent State University. Her current work focuses on weight stigma through an intersectional lens. I think a question came up on that earlier as well. She explores how individuals with multiple marginalized identities experience weight stigma, as well as other forms of prejudice and discrimination. And Mary, Dr. Himmelstein, thank you so much for being here. I really appreciate the opportunity to work with you again on this important topic.
Yeah, glad to be here. And that was amazing with you and Eden going back and forth. I always get something from these presentations.
It's a lot of fun. It's a lot of fun. Hopefully those watching also are getting something as well. But so let's dive in. Weight stigma. What is it? Why don't we just start with the basics?
Yep. So when we're talking about weight stigma, we're talking about people being devalued, made fun of, treated as less than because of their body weight. There's a couple of different terms that are rolled into weight stigma. So it could be prejudice, and these are going to be attitudes like, I don't like people who have a higher body weight or who have obesity. That's prejudice. It can be stereotypes like, I believe people who have obesity are lazy, they're the architects of their own ill health. I've heard that said before. They don't have willpower, they could lose weight if they just wanted to. Those are stereotypes about obesity. And then discrimination takes it a step further. So it's about treating someone differently because they have higher body weight, not hiring them, not recommending them for promotion, not getting into graduate school because they think you lack the grit, for example. That's what we're talking about when we're talking about weight stigma. And it's a really pernicious continuing problem.
Yeah, and hopefully everybody listening recognizes that. And now, what's the difference in bias? There's got explicit and implicit, and give us a little bit of overview of what that all means.
So explicit really has to do with what I just talked about. So those are the overt attitudes. So those are, I don't like this group of people. Implicit is really something that we get from our larger culture because of the way that we're socialized. So over and over and over, we get these messages that thin is what is good and fat or obesity is what's bad. And these also influence our behavior, but in a sneaky way that we're not necessarily realizing. That's what makes them implicit or unconscious. So if you believe that people with obesity are lazy, even at an unconscious level, you're going to interact with them differently than someone who doesn't have obesity. And so those implicit biases also drive our behavior. They're things that we feel that we're not necessarily immediately aware of.
And therefore they're harder to recognize.
For sure.
But
yeah.
You've got statements that come out. I think you helped to put this list together.
Yep. So people will talk
What do
about things like being in a medical appointment or being in a company, and they don't even want to see me. They think that I should just change the way that I eat. They're making assumptions about my eating habits. I must eat a lot of fast food. I must be drinking a ton of soda, that I must be really unhealthy because of my body weight, that again, you could lose weight if you really wanted to. All of those are reflecting bias. And I'm going to add another one here. The way that we talk about food in terms of moral language also contributes to this. So if you say things like, oh my gosh, I was so bad this weekend, I had 2 brownies instead of one, or oh, I ate the whole plate when I was at whatever restaurant, I was so guilty, that also is contributing to that bias, that moralization of food.
Yeah, it is hard enough to deal with a chronic condition, a chronic disease. It's even harder when you build that weight of that on top of it. And I mean that pun intended. And you look at the bias and the stigma, and I know we've touched on some of this, but this word cloud can be pretty powerful.
Yeah, so when we're talking about stigma, especially around weight, we tend to have this idea that like sticks and stones don't break my bones and words can never hurt me. And that really is not the case with weight stigma. I've worked with commercial dieters who talk about stigma has been a thing that has colored my whole life. It has limited the way that I present myself. It has prevented me from putting myself out there. It has stopped me from asking or talking to people about what's happening when people are judging me for my weight, often because one of the top voices of people who are being judged are coming from friends and family members who are just trying to be helpful. But you have to keep in mind that those, oh, you should try this diet, or you need to do this, or you should eat more of this, or you should take this supplement. Those are things that are happening over and over and over and over again. It's not the first time that they've heard it. And even if someone's trying to be helpful, it can be really, really harmful. It can cause someone to go into a shame spiral. And this contributes to what we call internalized weight bias. So, this is when it's not other people who are talking negatively or devaluing us because of our body weight, but this is when we start to do it to ourselves. And that internalization component is probably the most harmful. It is predictive of a ton of different problematic health behaviors, mental health issues, physical health issues, which we'll get to in a couple of minutes.
Yeah, yeah, exactly. Now there are multiple levels of stigma. So let's give us an overview of that, because it explains why it's so hard to break.
Yep. So we just touched on inter and intrapersonal stigma. So intrapersonal stigma is I don't like myself because of my body weight, or I'm going to be worried about what I'm going to order in front of other people because I don't want them to judge me. Interpersonal is, people giving you diet advice unsolicited, people calling you names. And then structural stigma is really about our environment. It's how we see obesity in the media. It's also about policies. So things like public health campaigns that are meant to be about obesity are often super, super stigmatizing. And you're essentially looking at yourself and seeing how the world sees you. And that is very, very problematic. And for policies, it could be that you have a weight limit, or you're not allowed to hire someone who's above this weight. There's a number of companies who have those kinds of policies. It could be charging people more for a healthcare premium because of their body weight, as we talked about, because it's costly. But that is a form of structural stigma. It could be the kinds of chairs that you have in your waiting room, in your office. Those are all forms of that structural environmental stigma. And policy is a great way that we can change it. And we'll get to that when we talk about what can you do about weight stigma in your workplace.
Yeah, that's really important.
So
It
someone
impacts
asked
our
about
health.
it
Yeah.
does. And someone asked about and mentioned social determinants of health. And I'm so, so happy that people are paying attention to this, because this is what I study directly. So, social determinants of health are those other things that are contributing to poor health conditions. So, if you live in an urban area in the inner city, you're going to be disproportionately likely to be exposed to pollution. If you are in an older building, you're going to be exposed to lead paint. Those are contributing to a social determinant of health, usually related to income. It can relate to the where you're living, eating. And stigma is also a social determinant of health. We talk about it as the enemy of public health. We know that weight stigma in particular has really strong tolls on one's psychological health. So not only does your body image and your self-esteem take a hit, but you see an increase in depression, depressive episodes, in anxiety, and in eating disorders. Not just the eating disorders that get a lot of playtime, like anorexia and bulimia, but also binge eating disorder. So having repeated binges where you're eating a lot of food and you feel like you're not able to control how much you're eating. So all of those are directly related to weight stigma, in part because one of the ways in which we comfort ourselves when we feel stress is to turn to food. We know that that psychological stress, that mental health also directly impacts our physical health, our physical quality of life. Stigma is what we think of as a chronic stressor. So this is going to be affecting things like your cardiometabolic health, so cardiovascular disease, metabolic disease. These are going to be causing dysregulation in your physiological systems, which we'll talk about in a minute. It directly impacts your health behaviors. So if you think about going to a gym and you feel unwelcome because you don't know how to use machines or because people are staring at you or taking a picture of you or making a comment about your weight, you're not going to go to the gym because it's a place where you feel or fear harm, fear harm. They also put you at greater risk for all of the diseases that we've already talked about, those comorbidities. So not only obesity itself, we know stigma contributes to weight gain, but also again, cardiovascular disease and metabolic disease, as well as cancer, sleep apnea, a ton of others.
Self-perpetuating. So let's get into those physiological risks. You just gets very technical, but walk us through this side of this.
Sure. So we know that holding all other factors constant. So these are going to be things like independent of someone's race or ethnicity, independent of their income, independent of their education, independent of their BMI. People who report weight discrimination have higher levels of all of these physiological determinants is what I'm going to call them. So C-reactive protein is a measure of inflammation. So people who report weight discrimination have higher levels of inflammation, higher blood pressure. So this can lead to hypertension, higher levels of what we call the stress hormone cortisol. And cortisol is really important because it does a couple of things. So it drives us to eat. So when you have excess cortisol, you're hungrier, you want to eat more, and it accumulates body fat, and particularly body fat around your abdomen. So we talked about your body wants to defend its highest set mass and that you're built for famine. This is what's driving that. So cortisol is trying to keep you safe from starving. It's accumulating that belly fat so that you're not starving. And then certainly it also increases HbA1c or blood glucose. All of those are risk factors for major killers of us. So cardiovascular disease, endocrine dysfunction, metabolic disease.
So again, we don't want any, and you just described the complications of diabetes. You've just described the complications of obesity, and we've tied it to stigma, bias, and the psychological pressures that go with being overweight, having obesity. And it is hard enough. I have lived with type 1 diabetes for 42 years. It's a different disease. It's an autoimmune disease. It's a bear. Okay. I wouldn't wish this disease on my worst enemy. It is hard enough to live. I've been fortunate. It's hard enough to live with this when you have access to everything, you get the education, you get the medication. But when you put the burden of it's your fault on top of it, which by the way, it's not, we're making it harder. When you're in a hole, step one is drop the shovel, and we're all still digging. Our society is still digging in this. And this I think is a powerful thing because these are scientific studies that have shown us what's happening here. And for the HR team, it's easy for us to have this conversation around if we have weight loss, we have stigma and the bias and all of this, it manifests physically. And this isn't something we're making up. This is proven. And if we're not trying to work on this problem, again, from our benefit plan perspective, then we're not solving that comment. Thanks for listening. And I loved this. I left this cartoon in. I don't have a lot of cartoons in this, but I'm gonna let you explain this.
Sure. So, one of the things that people who have obesity will talk about is that physicians, healthcare workers tend to be the number two most reported place where they experience weight discrimination. And this can look like coming in with knee pain or back pain, which can certainly be weight related, but blaming it all on the weight without investigating the issue. So, when I gave my job talk to become a professor at Kent State, I talked about a really egregious case. And this is someone who would go to her doctor and tell her doctor that she was having problems breathing. And she'd put on a little bit of weight. And so her doctor would say to her, you know, you're having trouble walking up the stairs, you're having shortness of breath because of this excess weight. If you lose the weight, you'll be fine. And it wasn't until she went to the hospital that they actually did x-rays and found out she had lung cancer. So that's an extreme story, but there's many of those. People talk about having every health problem being blamed on their weight. People talk about getting judgment from physicians because they're just like everybody else. They play, this game that, oh, it's just exercise and eating right, and they're just as susceptible to biases as the general population. And so we need more education for healthcare providers, for more people to be like Dr. Miller, and understand that this is not the patient's fault, and that often this isn't the first time that they've heard that their weight is a problem, or they need to lose weight, or they should try this diet. Often people are hearing this over and over and over again. And it's one of the primary reasons why individuals might avoid the doctor, including preventive exams, which we know as HR individuals, we really need them to do, because if you catch a disease early, it's cheaper to treat.
Yeah, yeah, and you've said a mouthful there. Prevention is a pound of prevention is worth an ounce of prevention worth a pound of cure. I got that whole thing wrong. It was Ben Franklin, but an ounce of prevention is worth a pound of cure. Investing in this up front is key. And the medical professionals, the healthcare professionals, and we saw Dr. Miller's slide about the conversation wasn't happening, and the amazing impact of a person with obesity who had been spoken about it had a 7-to-1 more likelihood that they wanted to actually do something about it. I mean, that the power of the conversation, is tangible from there. We have to go way societally to get the stigma and the bias out of our psyche. And I think that also attributes why the World Health Organization classifies obesity as a disease in the 1940s, and it took the American Medical Association till 2013 to do so. It's not shocking that we still have work to do, but let's recognize that we have that work to do. And I appreciate the opportunity to have that part of the dialogue. So let's talk about where it lands in an employment scenario. Where does weight bias manifest?
Yeah, so this can be unfair hiring practices. So, say that you work for a commercial dieting company, or for a gym, or for a company that has a receptionist, and the first person that you see is not likely to be a person who has obesity. They're less likely to be hired for front-facing positions. They are less likely to be hired for positions in which they are interacting directly with clients. And we know this from lab studies. We know this from real data. So if you have a thin applicant and a higher weight applicant and they have the exact same qualifications, the thin applicant is going to win almost every time. So we definitely see this in unfair hiring practices. We also see this in terms of lower wages. So there's a study here talking about a woman with obesity who has her bachelor's degree is going to make about 12% less when she's hired, and then also up the chain for those promotions and salary raises. We also know that higher weight employees tend to face harsher discipline for absenteeism, for example, relative to thin employees. They're more likely to be fired. And all of this really traces back to those negative stereotypes, the belief that people with obesity are lazy. If you can't take care of your own body, how can I expect you to do well in this management training? How can I expect you to interact with clients well? How can I give you that promotion, even though you've met all of the standards for it? All of those are ways in which this is probably manifesting in your offices.
Yeah, and again, hopefully the HR teams are seeing this and listening. Now let's talk about what we can do about it. What can they do to reduce this? And I think we've got some great suggestions here.
For sure. And I'm going to steal one of George's lines here. So he talks about it in terms of just like on an airplane, when you're supposed to put your own oxygen mask on first before you help others. That is also what you need to do here. So one of the first hurdles that you can do when you're looking at weight bias and stigma is to identify your own biases, to recognize how you feel about people with overweight or obesity. Do you see someone who has high weight and immediately get like a bad feeling in your gut or feel a little bit disgusted? Recognizing those biases is the first step to being able to effectively address them. Also, having a policy on your books that we don't we don't tolerate any kind of weight-based mistreatment. So investigating reports where someone's talking about being teased, being bullied for their body weight, making sure that if you have a non-discrimination policy in place, which almost everyone, well, I think everyone should, right? Because it's legal. But adding weight to that policy and taking it seriously when people are reporting that they are experiencing weight stigma. Almost all companies have diversity training, sensitivity training. It already exists when you're doing your new pack for new employees. Add weight to that mix. Talk about how we respect everybody regardless of their body size. And then check your own interviewing practices, your promotion practices, your hiring practices to try to identify places where weight might be an issue that are preventing people from being promoted, being hired, to make sure that it's safe and fair for everybody, regardless of their body size.
Yeah, thank you very much. And these are very tangible things that that need to be purposefully thought through and done in order to get to a fairer environment without that stigma and bias. So thank you for that. And let's get into workplace wellness. I teased that when we were talking about the importance of education and the importance of understanding. There are several things that they can do, and there's some things they shouldn't do.
Yes. And I'm also going to answer this Q&A. So men and women report similar levels of weight stigma. What is different between men and women is that men internalize it less. So they feel they dislike themselves less than women do relative to their weight. And it's partly because men can get away socially with being a little bit higher weight without experiencing the same level of teasing. So now let's get on to my favorite topic, which is workplace wellness initiatives, mostly because I love them in my own workplace. But starting off, one of the things you definitely should not do, and if it's currently at your company, you should eliminate it. You should never have a weight loss competition in the workplace because it does the opposite of what you want it to do. When you are doing a competition like, oh, the biggest loser for my office, oftentimes what happens is people are engaging in unhealthy practices to lose weight. And immediately when they go back, they're going to gain that weight back. You want to focus on long-term lifestyle changes and start small. Tiny steps are going to get you to where you want to be. So what you can reward instead is you went for a walk today, you exercised, you joined your gym, you went to your gym 3 times a week. If you want to focus on reducing chronic disease, so things like hypertension, reducing type 1 or type 2 diabetes, reducing cholesterol, focusing on those markers as opposed to just focusing on the number on the scale. So have rewards built in for you improved your cholesterol. For example, you went to a class about how to regulate type 2 diabetes. Want to reward healthy behaviors as well. So this can look like a lot of different things. It could be like having a free gym membership or a discount at a local gym. This could be about having a time during your workday where everyone's allowed to exercise potentially in a group setting. This can look like having cooking classes or a class on lunch and learn about how to pack a healthy lunch. And then making sure that you have made your stairways really attractive so people want to take the stairs. They're not like these dark, gloomy places that may or may not feel unsafe. And making sure you have nutritious food options available. If you have vending machines in your office, making sure people have a cold place to store their lunch, for example, their salad that's going to wilt if it's in a hot lunchbox all day. Having those nutritious options is also really, really important, and making sure all of that is available to everybody, regardless of their shape or their size.
Awesome. Awesome. And, employee of the month, their parking spot should be in the back of the parking lot. Give them the longer walk and reward them for that opportunity. Dr. Himmelstein, thank you so much for sharing this today. We really appreciate this. And I really appreciate everybody being on this. I think we've answered the questions that have been in there. We're gonna be out of time, but happy to send other answers via email if people want to throw more questions in. I want to thank again Dr. Himmelstein and Dr. Miller for sharing their expertise today. I want to thank you for your attention for today's program. I hope you got something useful out of it. You know, HR people do not get thanked enough for caring about the people and their plans. And you've got a thankless job because everybody comes to complain. So hang in there, and thanks for what you're doing. And please consider helping your people deal with this chronic disease called obesity. Hester, I'm going to turn it back to you. Thank you for your time.
I'd like to thank our speakers as well as all of you for joining us today. If you'd like to view this webcast again, the archive recording will be available on the hr.com website within 24 hours. The webcast credit will show in your hr.com account within 2 business days, and we'll also send you an email with your credit information. Your feedback is important to us. Please take a moment to fill out the exit survey that opened in a new browser page on your computer. This concludes our webcast. Enjoy the rest of your day.
Thanks, everybody.